colleagues. So we are a bit ahead of the timing. It's good. And so I propose with together with Mélanie Leroy to share you what is Transisome and the date of this project. Is an ongoing project. We were lucky to get funding from the French National Health Research Corps about rare disease. So the name is Transisome because it's an acronym to tell you that we want to evaluate the long-term outcome of patients in adolescents operated at birth at the age of 13 to 14, and look for molecular signatures of future complication. We'll do the talk with Mélanie Leroy. You all know her because she was organizing this nice meeting, and you were in contact with her, and she did everything. And thank you, Mélanie. And she is full-time on this project and very devoted to it. And we see that it is quite ambitious in terms of number of patients to be recruited. So, and I will start, and then I will later go on with the presentation about where we are and what we are expecting. So, the rationale is, as you know, in developing countries, thanks to the surgical and neonatal advances, now the rate of mortality is very low. We have a population-based register in France. And the mortality rate is 7% in France, even lower in the metropolitan area compared to overseas departments where it's more difficult to access pediatric surgery and neonatal units. So we are quite less than 5% in France, metropolitan France, of mortality. But what we learned this last decades is the morbidity is high and is going on, as Madeleine showed you at the beginning, not only during the neonatal period, but all over life. And there are more and more data about adolescent adults showing that they still presented the digestive, respiratory, orthopedic, nutritional problem. And when you look at the literature, there are very few population-based data on the outcome on the long term. Most of the papers published are from tertiary center, highly specialized center, where they follow the highly selected population in their hospital. And when we looked at the molecular signature of the risk of complication in esophageal atresia, there are very, very few papers published and very, very few knowledge on that, except for eosinophilic esophagitis and some on the Barrett's. We also have the ambition to integrate both clinical data about the follow-up of these patients and also the molecular signature we get. So what we know about long-term digestive outcome, that here are the paper published in adults. You see adults with esophageal atresia, age more than 18 years. And as you can see, dysphagia is very frequent. Gastroesophageal reflux symptom, very frequent. Esophagitis, both endoscopy and histology are very frequent. And even endoscopic Barrett esophagus is frequent, at least gastric metaplasia, also intestinal metaplasia remain much rare. And even if you look more at the long-term outcome and the theoretical risk of esophageal cancer today, there is 18 cases published on esophageal cancer in patients operated at birth with esophageal atresia. You can see on the right part of the slide that most of them are young adults. 22 is the youngest one, and 16 in some case. And there are two types of cancer which has been reported. Most of them are epidermoid, which are more associated with scare in the esophagus, dilatation, surgery, dysmotility. And some of them are adenocarcinoma associated with Barrett esophagus, which is a precancerous lesion due to a chronic gastroesophageal reflux disease, which is very frequent. Just to mention a very rare case report of the youngest, to my knowledge, never be reported in a so younger child, reported last year in a 13 years old boy with esophageal squamous cell carcinoma, very advanced and a poor outcome in this case report. Next slide. So if we are looking at what we know about molecular profiling on Barrett esophagus and the risk of esophageal cancer in children, there are very few, a lot of paper in adults, of course, but very few. This one is a very, it's from UK, and it's very old one where they look at young children, 10 children presenting with Barrett esophagus, meaning intestinal metaplasia. Among these 10 children, 2 or 3 were operated at birth for OA, so not all of them were esophageal atresia patients. And they did at that time, it's an old paper, in situ hybridization for probes on the esophageal biopsy during endoscopy and paraffin and amended biopsies. And what they see that even these very young children, I think the youngest one was 18 months of age, had 50% of common genetic markers between children and adults with intestinal metaplasia Barrett esophagus. Looking at now another emerging complication, which is eosinophilic esophagitis, that is more frequent in esophageal atresia patient compared to the general population. And it's thought to be 10 to 15% of esophageal atresia patient will present EOA during their evolution. Next slide. And according to the esophageal biopsy molecular profiling, this famous paper by Usha and American colleagues, where they compared esophageal biopsy for esophageal atresia patient with and without EOA, and with the control patient and the patient without EOA and esophageal and eosinophilic esophagitis, showing that esophageal atresia patients share in 25% the same genes and EOA. These are genes about barrier function or inflammation genes, so showing that this esophageal atresia patient who presented EOA have quite similar, or at least common molecular profiling compared to classical to EOA patients without esophageal atresia. So that's the only things we have. So the methods we are following is to study the national French basis multicentric cohort study, recruiting patients for all the French qualified for esophageal surgery at birth. As you probably know, France has a national plan for rare disease where reference centers have been appointed and have been officially recognized by the health ministry, and they have to follow a common protocol. They have to collaborate with patient care with a different protocol, and we are lucky to be the coordinator centers for France and to work very closely with all the French centers taking care of this patient. So our primary objective is to assess prevalence of GERD in adolescents. That's the basis where we, with methodologists, account for the number of patients we need in the study. But we want to go, of course, more. We want to answer more questions, and we have several secondary objectives where we want to identify risk factors and multi-omic profile for children from esophageal biopsies. We explain you and some blood sample in adolescents compared with the control group. And so we would like to better understand the disease evolution, so risk of Barrett or cancer and the risk of EOA especially. and also to know better about their outcome in adolescence, and combine these two. So we are, our primary outcome is good, so we will define it as the most objectively as possible with a pH impedance and endoscopy or anterior reflux surgery. And we have many secondary outcome PROMs with patient quality of life using generic and specific esophageal atrophy quality of life, which is being validated in French. It has been validated in several other languages. Nutritional status, type of feeding, dysphagia. So I will not do the list of things, and also have omic profile on these patients based on esophageal biopsies to look at protein abundance, metabolic abundance, RNA profiles, and methylation status. So to have information about metabolite, genetic, and epigenetic information in this population, and in 1/3 of the patients to replicate this analysis in blood taken especially for that during the study. So next slide. Our idea was to take advantage of clinical endoscopic follow-up, and we start in France thanks to the National Plan for Rare Disease. On the left, we have Renato, which is a population-based registry where we record clinical data of patients from birth until the age of 1 year. This register has been approved by the health authorities in France as a population-based registry, and today it's close to 3,000 patients in the database. Then we take the opportunity of using data from COMAT-6. COMAT-6 was a study where we followed nested cohorts of children born between 2008 and 2011, 2010 and 2012, where we were able to have a follow-up with very precise data about clinical status, weight, age, complication, whatever, at the age of six years. And Transisome will contact again this adolescent now, age 13 to 14 years old, for the clinical part of the study.
The Transisome project, it's a national project. Here at the map of the French centers, it's actually all the French reference centers for the esophageal atresia. They can be either on the metropolitan France or on overseas origin. It's important for us to have an overview of all the patients in France, even if the environment is different on the overseas region. If I make a focus on the biopsies, if I take the timeline that you just saw, so we plan on including 300 patients. From those patients, we think that we will be able to retrieve 150 esophageal biopsies. And they probably have older biopsies that they did when they were younger. So we think we will be able to retrieve 75 biopsies on patients where they were 6 years old and 50 when they were 1 year old. And of course, they must have underwent endoscopies at different time points, but we will also retrieve them in order to have a longitudinal analysis. And the other part of the analysis from the biopsy will be to compare them to control, but only for the 13 to 14 years old patients. So we aim to include 150 controls too. Controls patients are patients that had a medical reason to undergo endoscopy, so they are not completely healthy, I would say, but the endoscopy was normal from the endoscopic point of view and the pathology point of view. The objective is another way of showing what Professor Beauchamp already went through. So the objective of the project is to define the natural history of 2 adolescents and identify risk factors for concomitant diseases. So we are gathering all of those data on the left side of the slide. And since the last study we had when we gathered data specifically for research is when the patients were 6 years old, we also are gathering retrospectively medical history to fill the gap between the 6 years old and the 13, 14 years old patient visits. And on the right side, you have the omic part of the project, which is actually more conducted by our partners, CRIS, Go, and the Billing platform. They aim to identify molecular markers in adolescents for subsequent complications. And as Professor Gautran said, we are looking for the abundance, we will evaluate the abundance of protein metabolites in biopsies, and also in blood, in all the biopsies we have. And we will also look at really RNA analysis and small RNA analysis, as well as methylation status on the. I will not go a little bit further on this slide because Sibylline already shared with you what we done together on the Transisome project, but just to help the people who might not be here when we present Kids France. So Transisome is a co-constructed project with parents and patients. So we have 3 committees: one parent personality committee, one patient committee, and one of adolescent experts in clinical research that are actually part of Kids France. One of the specificity of the project, at least from my point of view, because it's new for me, I would say, it's an open science project. So at the end of the project, we will archive our data on platform, which will be open and flexible, which will be a front cohort. And we have to follow the FAIR framework, which stands for findable, accessible, interoperable, and reusable data, meaning that we, if someone is looking for data on adolescents born with galateria, it should be able to find the fact that we already gathered those data. And if he wants to access it, he or she will have to contact us and open request, and we will evaluate if it's valid objective to access the data. And we will work we are already working when we are collecting the data, but we will also still working on them afterwards to make it sure that it's interoperable with other data sets that other people might have collected, and to make sure that it's reusable, that on top of the data themselves, we will also add some documentation to explain how we get the data, what we really mean by this item, and what is the different options for which item, and so on. So it will be the data and a bit of documentation on the data extraction. So when I said the end of the project, I meant 2028, probably, or maybe a little bit later. So the project started in 2022. We are almost at the end of the inclusion period here. And so mid-2026, we will have hopefully all the patients included, all the samples retrieved from all the centers in Lille, and we will be able to start the phenotypes analysis as well as the generation of omic data, and a little bit later to start the metabolic analysis. If I take a snapshot of the project today, so we have 34 centers. All of them are allowed to include patients, and thanks to this network, we were able to include 178 patients into the main study and 48 into the plasma study. Our goal is to include 150 patients in this study as well. If we look at the inclusion dynamic, on the left you have the main studies. So our goal is to reach this point by May 2026. We would like to include 300 patients. So I think it's reachable. I'm a little bit less confident on the plasma study because our aim is to also get here up to 150 patients by May 2026. Unless we have a very steep increase of inclusion, I'm not sure we will be able to meet that goal. Another way of looking at the dynamic of inclusion is to look at the map and see. Sorry, it's that. Sorry, I need to change my. So it's a video showing when time goes by, each centers will have a part of the circle turning blue, meaning that one patient has been included. So you can see that it's the beginning of the study and not many centers have already included patients. But what you can also see is that when they start to include one, they keep including, meaning that when the process is well organized and everybody knows what they are supposed to do and at what time, it works quite well. We don't have a lot of refusal from the patients. Some patients are either lost of follow-up or their comprehension of French is not good enough to make sure that they have very well informed information to participate. So now we have 78% of the time, sorry, it's French. The time has been elapsed already, but we include 58 of the patients. As I said, we think we are in a good dynamic and we will be able to meet our goal in a timely manner. So, the project is getting guidance from several committees. First, it's just on the left, it is not order of importance, but the steering committee, which is suggesting strategic decisions, the scientific advisory board, which some of these members are here, are suggesting scientific decisions. We also have feedback from user representative committee, the parents, the patient, and the kids sponsor group. And all of those suggestions are taken into account in action actually by the executive committee. If you want to know more about the Transition project, there is a website. Sorry, the link is in French, but on the top right of the page, you can switch to English. You can also follow us on LinkedIn or on Blue Sky. And if you want a little bit more detail, we have more comprehensive description of the methodology on the BMJ Open article. You can scan the QR code. And if you are looking for a good reason to come back to Lille, and to come to Lille, the ESGAN meeting, the 58th annual meeting of the ESGAN Society is organized here in Lille in June 2026. That's all for us. If you have any question, we are very happy to respond.
And just one question, I assume the size of the bubbles on the diagram,
sorry,
is it something to do with caseload, is it?
Yeah.
Okay.
I didn't.
I wondered whether it was a test for our geography of the biggest cities in France.
No, it's according to the eligible patient.
More or
I
less.
think I know most of them.
It's more close to the side of the city, of course, but there are some geographical differences.
Yeah.
It means these are all the university hospital in France.
Yeah.
And all of them are belonging to our network of patients.
Yeah, excellent.
So these are in theory, the number of patients aged 13 to 14 to be included in each of these centers.
Okay.
And so we are sending them every month you update to push on the recruitment because it's quite hard to have people really mobilize on such type of.
And Melanie, can I just ask, obviously you've shown them quite nice graphs for patient recruitment and for plasma samples. But for patients, what's the progress in biopsies? Because obviously that's kind of key to it.
Yeah.
So you need to locate them and get them sent, right?
I have only vision of the lead patients so far, so it's quite a narrow vision. Most of them have biopsy. We actually thought that we can associate biopsies collecting between 10 and 14, so the clinical of 13 and 14. So most of the patients have biopsy on that time frame, and most of them have the biopsy associated. I have actually no idea about the other centers because due to funding restrictions, we asked them not to send the sample one by one. So once they have 10 of them, they can send them. But most of them don't have 10. So, or maybe they just didn't look into it yet and ask the pathology department to take them out to the archive.
Our official recommendation in France to perform endoscopy with biopsy at the time of adolescence before transition. We don't know exactly if it's fully followed by all the centers in France. But at least our expectation is to have, we expect 300 patients and 150 biopsies. I think if 50% of the center fulfill all the recommendation, we should, but we don't have the information yet. But it's a very critical issue because all the audits have to be done in biopsy.
I have a question, but that's for Ségolène. because we are struggling to include patients in the plasma form, because these patients don't have usually blood sampling. And so do you have, or do the patients have any clue for us to know how to explain it to patients, or to have some arguments to ask them, please, are you agreed to participate in this part of the study?
So they did it when they reviewed the informed consent document and the informed consent for the young people. And for them, they said that the one way to have maybe a blood sample or to have something like this is to explain exactly what it would be used for. So it was not explained that much, and they provided more explanation. Looks like it's not completely sufficient. So the numbers are not only due to referral from the patients, they are also because not all centers are included into the plasma study for this, and I don't know why, but the centers who are including in this sub-study are not the ones who are including the most. Even they have the biggest caseload, but it's not how we should them at the beginning. But there is some also organization issues. If the patient is too late and the blood sampling cannot be frozen on time, they won't take the sampling. So it would be interesting to know the part of the logistics and the part of the refusal from the participants. If the part of the refusal for the participants is not that high, I'm sure we can do much for the informed document, but if it's the logistics.
The biopsy, the endoscopy, that's also on the counter base, or it's when you think they need to, you need to.
The biopsies are taken according to the normal follow-up, the routine follow-up of the patient. We don't do biopsies and endoscopy of biopsies only for the study. But the recommendation in France, as in the ESGAN-NASGAN consensus, is to perform at least an endoscopy with biopsy at the age of 1 year to all patients with regular atresia, one at the age of 10, and one in adolescent at the time of transition. So we take the opportunity of this biopsy. They are at the pathologic labs. They have to be kept for 35 years or 15 years because they are children and they cannot put this out, so they have to keep it. So we go to the pathology department and take the biopsy. We were there in paraffin, just to have some slides again taken for the analysis. So we don't do any specific endoscopy for this study. It would have been very difficult to have, at least in France, to have ethical agreement. So we just have ethical agreements for the blood sampling because blood is on top. It's not included in routine. Okay. If there are no other questions, Simon,
Frederick, if you excuse me, after we go, so have to grab a very, very interesting workshop. Thank you very much.
Take your back.
Okay.
So Simon, you can.
So Jimmy and Jimmy is on. You're there.